And friends, it is my great honor and pleasure to welcome you to our 8th EndoSwiss meeting for diagnostic and therapeutic endoscopy. Our meeting is hybrid, and we are very pleased to welcome an outstanding international and national faculty here in Zurich. We are very honored that our meeting is highly appreciated by the endoscopic community all over the world. So far, we have more than 1,400 registrations from 117 countries in the world. And at this moment, I would like to thank our friends and supporters who promoted our workshop all over the world. Focus of the meeting will be to learn the latest innovations in endoscopy and their potential role for our daily clinical practice. And in times of conflicts, endoscopy connects. This is our motto, and patient's care is center of our doing. I would like to address a big thank you to the industry, and we all know that without the tremendous support of our industry, such a meeting would never have been possible. Thank you very much. Let me start now with our satellite symposium, and I cordially welcome my co-chair, Professor Jan Borowicka from St. Gallen. And when we talk about innovations, I think there's no better pioneer in endoscopy than Professor Haruhiro Inoue, who will start this session. Professor Inoue is professor at Showa University in Tokyo and director of the Digestive Disease Center at Koto Toyosho Hospital. For his brilliant achievements, he recently got the SAGES Award, and his presentation today, and you have to get a taste of this. His presentation is Innovations in Non-Suturing Closure Techniques. Haro, the floor is yours. Thank you.
So hello everyone. I really appreciate all the organizing committee, particularly there's Dr. Stefan Siewald, his kind invitation to this great conference. So I'd like to talk about the, yes, please, not this image. So I'd like to talk about the tissue approximation method. So we call the loop 9 and the loop 11. That is a non-suture closing technique. So okay, let's go. So of course, everybody knows the overstitch and the Stuart from Olympus. These two devices are most reliable closing device. So, but the overstitch and the suture art so ideal, but technically not easy, at least for me, and the maybe a little bit expensive. So we are thinking how to close the defect using clip and loop or line. Then, so I'd like to demonstrate the loop 9 closure. It's a, in the principle of this loop 9 is the, it's a like interrupted suture, single suture. So like this. So original concept was end loop. That is commercially available from Olympus. But apply the end loop to the tissue, so we need a double channel scope or keep it outside the scope side by side. So we are now thinking the passing through the 2.8 working channel, this end loop. So this is what we call the loop 9 because it looks like 9, figure 9. So method is to the stripping knot technique. So first, we place the loop 9 in the site of a tissue defect. So keep the one side, the other side using regular clips. Then, so after that, we close this loop. Okay, this is actual procedure. So now we are placing the loop 9 that try to catch the one side. This is a full thickness resection in the stomach. So the other side. Then, so we catch the tail, the loop, and then so felt project that push the sliding knot to make it tight closure, like this. Okay, so this is our second loop placement. It's the same one. Okay, once again, so catch the one side, and then after that, we place catch the other side, and then after that, just close the loop. That's all. So third one is the same. So anyway, so in this case, we close the defect like this using a loop and clip. And left, you can see a resected specimen. This is a GIST tumor in the stomach. Okay, 6 weeks after this procedure, still the clips stay there, but within a month, so all these clips are gone, will be gone. So we applied, so Dr. Mayo, so Tanabe, so she reported that we applied this loop 9 closure to the colon ESD, after colon ESD. So this is an actual procedure. So this is a Dr. Mayo performed the colon ESD, and then so catch one side. So we can put the this loop 9 through the 2.8 working channel and the other side. Okay. And then after that, catch the tail. Then close it. Anyway, so like this, we can close the defect effectively. Anyway, so this is the data at the time of 89 straight case series. And the mostly right side colon, and the closure time is 15 minutes total in each defect. So closure time, so one loop is 5 minutes. Okay, so sustained closure rate is 95%. No complications. So we can apply this to right side colon, the patient who has the anticoagulant. So the size of the defect is more than 2 centimeters, is an indication of this closure. So next, I'd like to briefly demonstrate the loop 11 closure. So this is blue line demonstrates the loop, and the fix the both end to the 2 arms, 2 legs of the clip. Then, so you can see like this. So we close a defect like this, a zigzag fashion. So this is a kind of a line-assisted defect closure. Okay, then pull the line and then makes the tissue defect close it tight. Okay, after that, so we place our stay clip. Okay, this is the actual procedure. This is a case of a poet. That is a step procedure, same. So anyway, so tumor size is 3 centimeter and 6. So it's a long tumor. So after mobilization, we are trying to resect through the mucosotomy site, but the tumor was too large, so it's impossible to completely mobilize it. Then we decided to place some extension of the mucosotomy, and then, so finally we had the big defect after removal of the tumor. So in this case, we close the defect step by step in a zigzag fashion, left, right, okay? So starting placing the anchor clip to the distal end of the defect, and then approach left, right. So after that, we pull the thread, then, so mucosal defect already approximated. So after closure, we pull it out the supporting thread. So we don't need any scissors. Okay? So this is a case of a gastric schwannoma. This is the last case. Okay? So snare traction. After traction, we place a mucosal incision. And then, so we are trying to dissect behind the tumor. Okay? So in this case, we have to, because this is a GIST tumor, so we have to cut the muscle layer like this. Okay. Anyway, we had the big defect of the stomach. So we can see abdominal cavity like this. So, but fortunately, no bleeding. Anyway, lateral flex view, we can see a big defect of the stomach, like this. So in this case, we close the defect using the technique of a loop 11. So catch the distal end of the defect, and then, okay. So we can see some fat tissue, but anyway. So in this case, we don't involve the omentum, just try to close the muscle defect, full layer defect directly. Anyways, the same way, left, right. Okay. This may be the, yes, almost close to the end of the closure. A zigzag fashion, and then finally pull the thread, and then we can make a effective closure. So after that, so just take off the supporting thread. You can see that just a loop and a good closure of the tissue. So this is a clinical course after procedure. So patient has no fever, and nothing happened. Then, so 5 POD. So, so this is our closure. So loop 9 is like interrupted suture, not a suture, but similar to the concept of the interrupted suture. And the loop 11 is like a continuous suture. Thank you very much for your attention.
Haro, for this outstanding presentation. I think your motto is not the bigger the better. You stay always modest and also cheap with the interventions. So if you have questions, please take the microphone. I would like to ask you, so you demonstrated us now loop 9 and 11. So we have different situations. On the one hand, sometimes you want to closure a defect which is not a perforation. And on the other hand, when you perform a full thickness resection in the stomach, you have already a defect. Could you explain again which of these suture devices are better for which situation?
So it depends. So if we have a big defect, at that time, loop 9, it's like interrupted suture, which approximate the center of the defect. That works well. And as I show in the esophagus, if the defect is longitudinally long, so at that time, loop 11 closure works well. Anyway, we can combine the loop 9, and after placing the loop 9 at the center as a stage suture, after that, we can close the tissue defect, the zigzag fashion using loop 11.
And for the moment, you are preparing these loops by yourself, or your fellows do. Is there any hope in the future that we can get it commercially?
Yeah. So yes, now we made that. This is all handmade, but in the future, commercially available. I think. I hope.
Okay. Yep.
Horst Neuhaus.
You need a microphone. Microphone. Sorry.
Thank you for an excellent presentation, and this idea to develop these kind of loops is quite impressive. What about your experience with the mantra clip?
Mantis clip, you mean? Yes. Yes. So I prefer to use a mantis clip to close a mucosa defect, and sometimes we use like this. So theoretically, mantis clip catch the tissue very well. So once catch the one side and then bring it to the other side and open and catch. So it's theoretically seems easy, but actually sometimes difficult to take the other side. So loop 9 and loop 11, we catch the bilateral end independently, so we can close the tissue much easier. So after close approximation of the tissue, at the very end, sometimes we use a mantis clip for firmly close the tissue defect.
Question from the audience. If you perform a full thickness resection in the stomach and you have no perforation, do you also treat the patients prophylactically with antibiotics? How's your approach?
Yes, 2 days.
Okay, thank you very much, Haru.
Yeah. Thank you so much.
I pass now to Jan for the second presentation. You can do from here.
Okay, now we ask Patrick Epley to come to the floor. He's head of the Department of Gastroenterology and Hepatology in Lucerne. He's one of the most active interventional endoscopists in Switzerland, and he was trained at the Royal Prince Alfred Hospital in Sydney, Australia, in interventional endoscopy. One of his focus, but not only, is bariatric endoscopy. He's board member of the Swiss Society for the Study of Morbid Obesity and Metabolic Disorders. And so nobody can better answer the question if bariatric endoscopy is ready for prime time. So Patrick, we are happy to have you here, and we are looking forward to your talk. Thank you.
Thank you very much, Jan, dear chairs, dear colleagues. First of all, many thanks to Stefan Seva, the organizing committee, for the kind invitation to this year's EndoSwiss. It's a pleasure to be here and to talk about bariatric endoscopy and its applications. The pandemic of obesity and its comorbidities, especially diabetes and MEFLD, is a huge challenge for the healthcare systems all around the world. The numbers tripled in the past 4 years, and the costs for obesity are still on the rise. Already today, America is Trump-like first in this category, and in 10 years, probably half of the adult population in the US will be obese. However, also in many European countries, we already have rates between 20 and 30%. But what's the role of endoscopy in obesity? In the past, endoscopy was mainly useful in the complication management after bariatric surgery. As early complications, we have to treat bleedings or insufficiencies using clips, stents, or sponges. As late complications, we can see strictures, ulcers, or secondary weight regain or dumping syndrome. However, nowadays, endoscopy is also a valuable primary weapon in the fight against obesity and its comorbidities, as well as helpful to perform revisional interventions. As you know, the therapeutic options against obesity are the classical lifestyle and pharmacological treatments which have limited efficacy. Also, it has to be mentioned that the newer drugs like tirzepatide with 20% total body weight loss could really be a game changer if we believe in the results of the SURPASS trial. However, we don't know yet about potential side effects, especially due to long-term use. Then we have the bariatric surgery, which is efficient and has good long-term results. However, this option is only chosen from one of 5 obese patients due to fear of surgery, complications, and pain. And between these two options, the endoscopic bariatric therapies have been positioned. They are less invasive and reversible and have hardly any complications, and they can be used to bridge to surgery as an alternative to surgery and to treat complications. Depending on what kind of therapy you use, treatment success is based on multidisciplinary care within an experienced obesity center. Which requirements endoscopic bariatric therapies have to achieve to be accepted as effective and safe? If you look at the recommendation from the ASGE, it needs, among other points, a reduction of at least 25% of excess weight loss 12 months after intervention and less than 5% of serious adverse events. In the meantime, several papers and guidelines have been published showing the growing interest about that topic. Soon also the ASGE and the ESG will publish together a brand new guideline. But what options do we have as endoscopists at the moment? The options have to be divided into interventions targeting the stomach or the small bowel. However, depending on the different options, it's always the question about efficacy, feasibility, tolerability, and safety. The method first used since almost 40 years are the space-occupying devices like the intragastric balloons. Nowadays, there are several types of balloons available with comparable results, but the problem is always the same. After removal of the balloon, the lost weight quickly comes back. Then we have a PEG tube-like system called Aspire, which had been withdrawn from the market last year. And last but not least, there are several suturing and plication techniques and systems which are actually very popular. At the moment, there are 4 types of such systems. Endomina and endozip are not that known yet, and there are hardly any studies available. Whereas ESG, endoscopic sleeve gastroplasty, and POSE, primary obesity surgery endoluminal, are the leaders in the field. Concerning POSE 1, I have to mention that initially the applications have been made in the fundus, and because the results of the essential trial failed to meet predefined weight loss endpoints and were considerably worse compared to ESG, recently the POSE 2 procedure was developed where, similar to ESG, mainly the gastric body is shortened and narrowed. But let's start with the most important data about ESG. The first large multicenter ESG study from Spain and the US was published in 2017. Total body weight loss after 2 years was around 18% with hardly any complications. The largest ESG study yet, with more than 1,000 patients, comes from Saudi Arabia and was published 4 years ago. Excess weight loss 18 months after ESG was more than 60%, and there was also an impressive improvement of different comorbidities. So to conclude, ESG effectively induces significant weight loss up to 2 years in moderately obese patients, appears to be well tolerated and safe, and improves also comorbidities. Here we have one of the most actual and relevant ESG studies published in Lancet a few months ago. The study was performed at 9 US centers, and 2 groups have been compared: lifestyle modifications and ESG versus lifestyle modifications alone, which means calorie diet and physical activity. The results were significantly better in the ESG group, the blue line, compared to the conservative line, the red one. Total body weight loss 14 versus 1%, and also for the 75 patients who crossed over from the lifestyle modification to the ESG group had a good result. In addition, ESG led to an improvement of most metabolic comorbidities. So the authors concluded that the intervention is safe and results in significant weight loss maintained for 2 years at least, and that it has important improvements of metabolic comorbidities. If we would combine ESG with a new generation drug like liraglutide, the results would even be better. We can see in this study 1 year after ESG, total body weight loss was 25% when liraglutide was added 5 months after ESG, compared to 20% without medication. So addition of a new generation drug after ESG results in superior weight loss and improved efficacy. But what about long-term follow-up ESG data? The results of this study showed a sustained clinical response up to 5 years. Also, I have to mention that in this cohort, about 25% of patients were additionally treated with pharmacological therapy, and 6% of the patients had a redo ESG. However, it seems that ESG also is effective on the long term. One of the key questions is if the surgical or the endoscopic sleeve is better. And this study showed that ESG achieved less total body weight loss compared to the surgical sleeve after 1 year, 17 versus 30%. But the surgical sleeve caused more adverse events, 3 versus 12%, and much more new onset GERD, so almost 0 versus 6%. A meta-analysis from last year with more than 6,000 patients showed similar results. However, prospective randomized trials would be helpful to finally answer this question. And here the latest multi-center study about POSE-2. As we heard, this procedure with a radically new suturing approach is more effective compared to the initially used POSE procedure, which targeted the fundus. To perform POSE, a transport instrument with special devices is necessary, and the use of a thin endoscope with less than 6.7 millimeter in diameter. In this study, 44 patients with a mean BMI of 37 were treated with POSE-2, and the total body weight loss after 1 year was 15.7%, and after 2 years, 12.2%. Maybe the COVID-19 pandemic had also a negative impact on the results. So the procedure was done in around 35 to 40 minutes. There were no serious adverse events, but a clearly positive effect on comorbidities. To conclude, POSE-2 is an effective and durable treatment and influences physiologic pathways impacting satiety. Here we see a short video clip of a POSE-2 procedure. So using the G-legs, the gastric wall is mobilized and hold with the so-called G-prox. And finally, the plications are fixed using the snowshoe-formed G-cat. Then this procedure is repeated for around 20 times in 5 or 6 plication rows. The stomach is shortened and narrowed, which implicates after that then weight loss. You can see how the plications are tightened. Exactly, and this is repeated 15 to 20 times. What about techniques and methods targeting duodenum and small bowel? We know that this is an important area in obese patients due to its endocrine function, signaling, and the evidence we have from bariatric surgery. Besides duodenal jejunal bypass liners like endobarrier and Valentix, we have the experimental method of magnetic compression anastomosis, and also the duodenal mucosal resurfacing, shortly DMR, which has more effects on diabetes and liver fat content than on the overweight itself, and probably brings the best effect in combination with drugs. 2 types of bariatric surgeries are common and performed in over 85% of patients. Sleeve gastrectomy in green and in red, Roux-en-Y gastric bypass. However, also bariatric surgery is not always successful. Weight regain or insufficient weight loss are common. We know the reasons for that are multifactorial and that the revisional surgeries have a high risk of morbidity. Therefore, endoscopic procedures should be used first line. What kind of options do we have after bypass? We know that the positive predictive value of weight recurrence is higher than 75% if the diameter of the gastrojejunal anastomosis is more than 25 millimeters. So to reduce this diameter, the method transoral outlet reduction, shortly TORI, was created. To reach this, we have several options, whereof nowadays mainly suturing and APC are used. Which technique is better, TORI using suturing, APC, or a combination of both? In this meta-analysis with 16 studies and more than 1,600 patients, full thickness suturing plus APC versus APC alone were compared. Full thickness TORI was mostly done in one session, APC TORI in 1 to 3 sessions, and the results concerning total body weight loss after 3, 6 and 12 months showed no benefit for the combination of suturing and APC. So both options offer significant and comparable weight loss outcomes and are safe. However, APC TORI required multiple sessions. But how long the TORI effect will last? The literature is quite unreliable due to a high dropout rate over the years and the fact that many patients during follow-up were treated with medications. In our own cohort, followed 62 patients for up to 4 years, and the mean total body weight loss after 2 years was 3 to 4%, after 3 years 0, and after 4 years the majority of patients showed further weight regain. So as a result, the intervention brings short-term but not really long-term success. A brand new option to perform TORI is BARS, Bariatric Reduction System. It's a new device from Ovesco. Using BARS, the gastrojejunal anastomosis is partially closed with an OTSC. In this short video clip, you can see how it works. So you do a semi-circumferential incision using an ESD knife, then you place 2 anchors, and you slowly pull the anastomosis into the cap and deploy the clip afterwards. Using the space keeper balloon, you are safe not to completely close the anastomosis. At our center, we have just treated the first patients a few weeks ago, and it will be interesting to follow especially long-term results. However, it's interesting, this approach, but there are no data available yet. One slide about potential complication of dumping, which is very common after bypass surgery. In this retrospective study from last year, 98 patients, 2/3 of them with severe dumping were treated with TORI, and 85% of them still had no symptoms 3 years after the intervention. Similar results were found in a meta-analysis also from last year. So TORI brings effective and durable resolution of dumping syndrome, often also on the long term, and that's also our own experience, which showed comparable results with a very good response of dumping syndrome after TORI, which also improved considerably the quality of life. Some last words about endoscopic revisional options after sleeve gastrectomy. Here are data for revisional ESG from a multi-center prospective study with 82 patients published 2021 in GI endoscopy. Volume and length of the sleeve were reduced endoscopically, and 1 year later, total body weight loss was more than 10% in 81% of patients, and even more than 15% in half of the patients. So this seems to be a good option in this situation. And finally, another endoscopic option would be the SNAP procedure. With this procedure, a duodenal ileal side-to-side anastomosis using self-assembling magnets is created. This is a combined endoscopic and laparoscopic procedure, and within several days the anastomosis is set up, as you can see in the video. However, this method is experimental, and we have to wait for prospective study results. So it's time to wrap up. Obesity and its comorbidities, it's a worldwide pandemic, and it needs lifelong therapy, often stepwise, as you can see here. And there is no need for competition between surgeons or endoscopists, or surgeons and endocrinologists, but it's all about teamwork. We have to find a good solution for our patients. So, bariatric endoscopy, ready for prime time? Yes, to treat complications after bariatric surgery. Yes, to treat obesity as a primary therapeutic option. and also yes for revisional interventions after bariatric surgery to treat dumping and weight regain, as we heard, after a bypass as well as after a sleeve gastrectomy. In future, probably mainly combination therapies like endoscopy and medications will be successful. Collaboration and teamwork is essential. Thank you very much for your attention.
Thank you, Patrick, for this excellent talk. You've really covered all subjects, topics. How long is your waiting list now?
So it's a good question. You know, in Switzerland, we had the situation some years ago when we started performing bariatric endoscopy. The surgeons were not only happy about that, because in Switzerland, surgeons are doing bariatric surgery and don't perform the endoscopy. So it was not the same interventionalist who is performing surgery or the endoscopic interventions. And then we had to find a way set together, and now it's okay for the SMOB, for the Swiss Society of Study of Morbid Obesity, that these procedures are done in a study in 3 centers in Switzerland, and all the patients, they have to fulfill the criteria which are necessary also for bariatric surgery. So they have to fulfill 2 years of conservative treatment before surgery and also before endoscopy. Of course, many patients, they call us and they want to come next week for an intervention. They would bring the money, but we don't do that, and I think it's the right way to do it. And so the waiting list at the end of the day is not that long, because most of the patients, they stay with the surgeons. And so at the moment we have, let's say, 20 cases a year in our center. And the other 2 centers the same. So it's still not that well known in Switzerland, this option.
Okay, please.
Microphone.
So I have 2 questions. The first question is regarding ESG. From where do you actually start the suturing? Do you cover the antrum, or you do the suturing proximal to the incisor angularis? Because I suppose the MERIT trial showed Bahram Abudai has been suturing from the antrum, but the traditional approach is to start proximal to the incisura. That's the first question. And the second is about Tori. You just showed from your own personal result that the weight loss is very modest, only 3 to 4 kgs. But at the same time, you showed that the dumping syndrome is very effectively treated. So why is the weight loss so modest when you have narrowed down the gastrojejunal anastomosis, and at the same time the dumping syndrome gets properly rectified?
So the first question, always started incisura angularis, so we don't touch the antrum and we don't touch the fundus. We start at the incisura angularis and go up until the fundus, but we don't touch antrum and fundus. I think that's the classical way. And the second question is about the tori. So this is a very good question, and we don't know the answer yet, because it's really like this. In our center, we do hardly any tories for weight regain, because we have seen in our population and in our study group, there is not really a good success. But we have very good results for dumping. So I think, let's say 90% we do for dumping, and just about 10% for weight regain, if the patients really want to have the procedure. Also, we tell them, listen, the results won't be great. Yeah.
Thank you.
Okay, are there any other questions? From the web, there is no other question. So thank you very much, Patrick, for this excellent talk.
Dear colleagues, the next speaker doesn't need any introduction. Professor Neuhaus is one of the most highly skilled interventional endoscopists, and his outstanding live demonstrations are well known all over the world. I can only mention now some of his achievements. He is the past president of the ESGE. Recently, he got the International Service Award from the ASGE, and he established one of the most successful international workshops, the Düsseldorf Life Symposium. At this symposium, the first ESD in Europe was performed, and the list goes on. And one of his special focus and passion is the pancreaticobiliary system, and he will talk now on current and future role of cholangiopancreatic cystoscopy. Please.
Thank you very much, Stefan, for this very kind introduction. Jan, it's a pleasure for me to be here and to participate in this outstanding conference. I would like to talk on CPS, cholangiopancreatoscopy. These are my disclosures. So we have three different methods for DPS: direct peroral cholangioscopy, or DPOX, mother and baby cholangiopancreatoscopy, MBCP, and single operator cholangioscopy, or cholangiopancreatoscopy. The term single operator is a little bit misleading because DPOX is also a single operator technique. So this is done with a pediatric gastroscope, for example, the Olympus GIF H180N or the XP 290N. Single operator, reusable. This device has a 4.5 millimeter distal diameter of the distal end. It provides, in contrast to the other technology, high-def image and image-enhanced endoscopy, for example, with the new AVIS X1 technology, TXI and NBI, four-way deflection, a large depth of field from 3 to 100 millimeters, and it has a 2.2 millimeter working channel, which is so far not available from any other instrument for cholangioscopy. The challenge for DPOX is the biliary access, because we have to overcome the angle between the duodenum and the CBD. And as these images show, either you advance the scope and it's more proceeding into the deeper part of the duodenum, or loop forms in the gastric stomach. But it can be done. Otherwise, the alternative is a guide wire or a balloon-anchored approach. As shown here, a balloon is inflated in the right hepatic duct, and then by pushing and pulling, we can advance the paretic gastroscope into the CBD. And as you can see, we get excellent image here with NBI. This is the hilum. Obviously, the balloon catheter is in the right hepatic duct. The challenge is when the instrument is not in a stable position and you remove the balloon, then there is a potential risk that it slips back towards the papilla. So this patient had a distal indeterminate biliary stricture, which is now here evaluated. Now with the NBI, and as I said, we can use forceps as we do for pediatric gastroscopy. The MBBC CP is a two operators approach, the mother and baby scope, reusable instruments, and the mother scope is a conventional therapeutic duodenoscope, whereas the baby scope is a latest generation, the CHF B290, providing an imaged enhanced endoscopy, TXI, NBI, two-way deflection, a large depth of field from 1.5 to 20 millimeters, and it provides a 1.3 millimeter working channel. So this is an example here in a patient with a hilar stenosis. We've just seen the cystic duct junction. We're approaching the hilum. And as you can see, we get an excellent image with the option of a detailed evaluation of the mucosal structure and switching to NBI also of the vascular structure. And here, this was a hilum. We can precisely define the interluminal spread of the tumor. We can exclude skipping lesions coming back here to the cystic duct junction. SOCP is provided with instruments either Spyglass DS, well established, and recently IMAX was introduced, not yet available in Europe, but I had the opportunity to use it in patients in North America. It's quite expressive. Single operator approach, disposable instruments, in contrast to what I've said before. But we don't have an image-enhanced endoscopy, four-way deflection. We don't know the depth of field, no information from the company. And the inner channel diameter for Spyglass, 1.3 millimeters, and for IMAX with a 9 French, they have two different devices. 9 French is 1.2 millimeter, and for the 11 French device, 2.0 millimeters. And the advantage is that they have a dedicated irrigation and aspiration connections. So coming to the indications, one of the most important diagnostic indications is the elevation of indeterminate biliary strictures, IDBS. And the aims of cholangioscopy are to visualize the lesion and to characterize endoscopically. Tissue acquisition under direct visual control, delineation of intraductal lesion margins, and evaluation of skipping lesions. The challenge is how to characterize ductal changes. There are different classification systems. I cannot go into the details. This is one of the most recently published for SPY DS, the Mendoza classification. You can see here the different parameters suggesting malignancy. And this multi-center trial finally showed an overall diagnostic accuracy of 77%. So quite impressive, and in any way far better than what is shown with fluoroscopy. An example here in a patient with PSC, we are just past the confluence. There is an indeterminate stricture in the anterior lobe on the right liver. And as you can see, a very tiny stenosis. And these should be evaluated before any manipulation, as shown here. Another advantage of cholangioscopy is that we can proceed to targeted cannulation. So it would be impossible to pass this stricture just with ESCP techniques. In addition, we can here proceed to fragmentations of intrahepatic stones proximal to the stricture. And as you have seen after dilatation, it's very difficult to characterize. But we have, of course, the advantage that we can take biopsies under direct visual control. Now, how effective is SOCP in combination with tissue acquisition for IDBS? A systematic review and a meta-analysis was done on studies with the digital system in a period of approximately 5 years, and they included only those studies with a control arm with histopathology of the surgical specimen, autopsy, or long-term clinical follow-up, and only studies that enrolled more than 10 cases. And in total, 11 studies were analyzed, and these involved 356 patients diagnosed through biopsies. And the results show, so for histological evaluation for malignancy, sensitivity of 0.74. This is by far better compared with any trial on ESCP with brush cytology or biopsies taken under fluoroscopic control. Specificity very high, so we rarely see false positive results, 0.98. Of course, you can argue these are uncontrolled series, maybe biased, and in many of these trials, we don't see an intention to treat analysis. And we were the first in our group who did a randomized control trial together with centers in Hyderabad and in Hong Kong on comparing SOC with ESCP alone. A small study, but the results showed superiority of SOC sensitivity of visualization, 96% compared to 67% if you do just ESCP. and the overall accuracy was also significantly higher, and the sensitivity for tissue acquisition, 68%, whereas ESCP with brushing showed only a sensitivity of 21%. Quite disappointing, but this was a prospective randomized control trial. So clear advantage for cholangioscopy. How about DPOX? There is a new classification just published in GI endoscopy from Korea, the Bushion classification, a retrospective single center study. So this may be a limitation, retrospective, but they enrolled 471 patients, 131 had neoplasm, and the technical success rate of DPOX was 97%, so extremely experienced group, and of those who underwent biopsy tissue acquisition, 95%. And this is what our Asian colleagues like, a very, very detailed classification. I cannot show explain the different criteria, but they characterize the structure and the vascularization. And as you can see, when we have irregular vessels, then we have an odds ratio of more than 50, so 50-fold higher probability that this lesion is malignant. And if we combine surface structure and microvascular pattern, then they reported on a sensitivity of 87%, specificity 82%, and accuracy rate of 84%. And these are just examples of their publication. On the left, you see this granular pattern of the surface. And if you would use just white light, as with SOC, then it's probably not very likely that you would judge on malignancy. But in combination with NBI, you see the irregular vascular pattern. And finally, they took biopsies, and this is an adenocarcinoma. Now, cholangioscopy, as I've mentioned, can be also used for preoperative evaluation of the resection margins of the intraductal spread of the tumor for exclusion of skipping lesions. This is more and more preferred now by HPB surgeons. And this study, a couple of years ago, was done in 118 patients with a presumed diagnosis either of CCA or IPMN of the pancreas, or biliary of the biliary duct. And cholangioscopy finally changed the surgical plan in about 1/3 of the patient, either by less intensive or more extensive. So this is a clear also advantage. So for therapeutic indications, here you see an impacted stone. So many of us know how much time we sometimes spend with mechanical lithotripsy, and this is very easy to insert here a baby scope. We have the excellent image under continuous irrigation. This takes 10 minutes to fragment the stone. We can follow the fragments, and we already see now a lot of smaller fragments which can be easily removed with a basket or with a balloon catheter. So many studies on cholangioscopy-guided lithotripsy. This is one of the largest series published by Amit Maidero, 17 centers in Asia, 156 patients. And as we can see, the stones were usually impacted, and ductal clearance was obtained in 80% in a single session. So very effective techniques for difficult stones. And we can also use SOC and also the mother and baby scope technology for evaluation of pancreatic lesions and also for lithotripsy of pancreatic stones in chronic pancreatitis. The challenge is when we have an association with strictures, then it's difficult to approach stones. However, our group with Christian Gerges and Thorsten Beiner recently reported on 40 patients, a prospective multi-center cohort trial. Technical success, it means intention to treat analysis with fragmentation and clearance of the PD in 90%. And as you can see, this is also followed by clinical success. Drop of the ITSPICI pain score and pain relief completely or partial, and adverse events are not higher compared to standard interventions in chronic pancreatitis. Further indications, radiation-free removal of bile duct stones. We can use baskets with these devices without any radiation. Removal of migrated endoprotheses on foreign bodies. All of you know how time-consuming sometimes to catch migrated endoprotheses under fluoroscopy. Resection or ablation of intraductal lesions, and percutaneous transhepatic interventions for failures of POCS. And this is just an example of a patient with previous left hemipatectomy, metastasis at the hilum. We already succeeded to drain segment 6 and 7 with percutaneous drains, but you see then segment 5 completely blocked. No chance to overcome this complete blockage with radiological techniques or with ERCP. And what we can do in these cases, we inject here contrast. You see no flow of contrast into the CBD. We advance a sheath over the wire. A 12 French sheath is enough. And then we insert a SPY Discover, so a shorter 65 centimeter long cholangioscope. And we can nicely identify the radicals here and advance a wire under direct visual control in this very angulated structure, and then in combination with fluoroscopy, you see the angulation here. The wire is now in the CBD, and then we can follow with dilatation, and finally we place 3 metal stents. So I would like to conclude. Current role of CPS undoubtedly the evaluation of indeterminate ductal lesions and treatment of bile duct stones not amenable to ERCP. In the future, we will see more and more requests also for surgeons for mapping of intraductal tumor extension, targeted cannulation of difficult strictures, especially at the hilum. We know how much time we sometimes spend with fluoroscopy. Extraction of migrated prostheses, foreign bodies, radiation-free interventions, and replacement of mechanical lithotripsy and ISVEL for biliopancreatic stones. All CPS methods that I showed are effective and safe. The choice depends on local expertise and indications, and we can expect a rapid technological improvement, especially in terms of imaging quality and image-enhanced endoscopy, as I've already shown, implementation of AI, larger accessory channels, and improved and novel accessories. And my prediction is that CPS will increasingly replace fluoroscopy for biliopancreatic interventions. So this is a fantastic conference here, but when you cannot wait for the next one, then I strongly, together with Thorsten Beiner, my successor in Düsseldorf, recommend to come in February to Düsseldorf. Thank you very much. Of course, Stefan is also our faculty member.
Thank you, Horst, for this outstanding presentation, these fantastic videos. Jan has a question, please.
More and more we are talking about green endoscopy, and the single-use, single-operator cholangioscopy has several advantages, but the disadvantage is that, as you said, the classifications with NBI are not possible. If you start to introduce NBI in SOC, maybe it will be even more cost expensive. In which direction are we going? Will we be able to have a mother-baby system that is not so fragile, or what do you think?
It has already been improved a lot. So the 290 is already a step forward, and now it can be also used with a new AVIS X1 platform. But the durability, of course, depends also on the individual expertise. So there is no doubt that the learning curve is shorter for the disposable instruments. But as I said, when you have enough experience, also detox is still an option. But I think compared to disposable duodenoscopes, this is a smaller amount of waste because we don't have so many cases now for cholangioscopy. And we wait for recycling technologies.
But I think we have to be honest, when I saw your videos from the disposable instruments, I think with regard to the white light, they are almost comparable with the others, or is this incorrect? So
the image quality?
Yes, image quality from the white light.
It's probably enough for most of the cases, no? But hopefully I showed. So as you said, I have commitments for Boston Scientific, for Microtech, as well for Olympus. So I'm not biased. But I didn't say this is the best image. Therefore, I showed the videos, and all of you got your own impressions. But I agree. When we see the progress on smartphones, then we can expect, even with the smallest CMOS chips, further improvements. Yeah.
Okay, thank you very much, Horst, for this outstanding presentation, and we come to the next.
Okay, we ask Professor Varadaraioğlu to the floor. He is president of the Orlando Digestive Health Institute and is professor of medicine at the University of Central Florida College of Medicine. He's internationally known for his expertise and research in complex gastrointestinal disorders, especially interventional EUS and ERCP. Shyam Varadaraioğlu has been the principal investigator of more than 20 randomized trials. He wrote a textbook on EUS together with Barpas, which is a milestone for EUS teaching, and therefore, and not only for that, we are very happy to have you here and that you have accepted to travel so far away from.
Oh, thank you. It's such a pleasure to be here, and thanks, Stefan, for having me. So Stefan has asked me to talk about EUS, and there are a lot of things to talk, so I picked up the top 7 topics and tried to spend 2 minutes on each. So I'm going to first talk on diagnostic EUS, and there are 3 hot areas on this. One is tissue acquisition. Yes, some small changes with the type of instrument that we use, and then there is what we call a detachable EUS scope. So tissue acquisition has been there for almost 25 years. It's very good. You get a diagnosis in almost 95 to 98% of the patients. And there are 4 biopsy needles in the market. I think Microtech has got a new needle, so that'll make it 5. But oncologists are increasingly asking us for molecular profiling. So the 5-year survival rate in pancreatic cancer used to be 5%, but now it's 12%. And it has changed not because of what we do, it has changed because chemotherapy is increasingly getting better. And it is targeted chemotherapy, so they want more tissue. So these days, routinely, when we perform biopsies, we not only get tissue to make a diagnosis, but we also collect tissue so that additional studies can be done. But there is not much data that has been presented, but about 20% of time, the quantity of tissue is inadequate. So we did a very simple randomized trial looking to see whether 2 or 3 passes is good. 1 pass definitely is not good enough, because if you have a sampling error, 1 is going to be insufficient. So we took patients with pancreatic cancer. Once we make a diagnosis in the room with a rapid on-site assessment, they were randomized to 2 or 3 passes, and what you find is that close to 100% of the time, you will have enough RNA and DNA. And this information is important because if you've got BRCA positive, they don't respond well to conventional chemotherapy. You have to give them oxyplatin-based chemotherapy. If you've got KRAS G12 mutations, then there are new classes of medications to whom they will respond. And if you've got ETV1 mutations, they don't respond well to chemotherapy. They always get metastasis and die. So these patients, probably chemotherapy should not be given. So at least in this study, what we showed is if you use the francine tip needle, and if you use what we call the stylet pull technique for better suction, if you fan the needle and you collect the tissue in formalin, and if it can be processed with paraffin, then this material can be taken away from the slides. You can perform molecular profiling successfully. So there are a combination of 6 things that you need to perform in tissue acquisition to reach 100% positivity with molecular profiling. The second problem with EUS is that occasionally it's not possible to pass the echondoscope if you've got strictures. And the most common thing is a problem with the cervical osteophyte, or if you've got esophageal cancer, and we tell that, well, if you can't pass a regular endoscope, it's almost advanced disease, so don't do EUS. And oncologists don't agree with it. They want biopsies from metastatic areas and so on. There's only one manufacturer right now who makes a slim echondoscope, and that is from Pentax. And this is a simple study that will show you why it might be important. So this is a patient who has got a Roux-en-Y gastric bypass. So at least in EUS, in the United States, every single day we have a patient with altered anatomy for EUS or ERCPs. So here we are doing what we call an edge procedure. So from the gastric pouch, you are accessing the excluded stomach, and you place a lumen-opposing stent, which is the axio stent. Then we suture the stent at the same session. And then you can drop any scope through the axios to go into the excluded stomach so that you can do EUS and ERCPs. Your regular echondoscope will not go through because it's about 14.2 millimeters. Even with a 20 millimeter axios, it's difficult. But the slim echondoscope, which is 11 millimeters from Pentax, can be easily advanced. And once you go down, you can perform whatever intervention you want to perform. In this particular case, this patient had obstructive jaundice, and you can see that there's a mass somewhere in the pancreatic head region, occluding the bile duct, and a tissue acquisition can be undertaken quite easily. We use ROSE, or what we call rapid on-site assessment, in our room, because in the United States, patients come with an expectation they will have a diagnosis at the same session. So we use ROSE, and then you can remove the scope and pass a slim duodenoscope or a regular duodenoscope to perform your ERCPs and place a stent in the conventional fashion. So when we did that in 2,000 consecutive procedures, there are 4 circumstances when a slim scope is important. Your Roux-en-Y gastric bypass anatomy in a jaundiced patient, it's indispensable. Second is, if the patient has got an esophageal stricture, and if you want to navigate the scope, a slim scope is useful. If you've got a big osteophyte, usually in an elderly patient, it's difficult to get the scope past the neck region, so it can be useful. If you've got a scope in the distal duodenum, the slim scope can be pushed much more easily than a regular echondoscope. And finally, in patients with gastric outlet obstruction, if you can even dilate marginally, and this happens usually in pancreatic cancer, then the scope will go. And we found that in 1.1% of procedures, a slim echondoscope is critical to completely, for a successful exam. A third development is something called an EndoSound. This is a US-based company. They've applied for FDA approval, and this is a probe and a laptop. So you use a laptop with a special software, and you attach this probe to the tip of your gastroscope or a side view duodenoscope. You can just take it anywhere you want. And then here's a video of a patient who underwent a liver biopsy. It's easy to assemble. It takes about 8 minutes. You can look at the quality of the image. It's, the EUS will play pretty soon. It's a reasonably okay image. It has been worked on the pancreas and in the liver. You will be able to perform basic interventions like FNAs and so on. We don't have much experience with things like drainage procedures or RFAs. Only time will tell. We expect this instrument to be approved by the FDA by the end of the year. And this might be a change. The probe is disposable, but I think you can use it for 40 procedures if you want. So how this will translate into the field and have an impact, we don't know. And there's no clinical data right now. So with interventions, I'll touch on a few things. We've got the RFA catheter that has been used from Taiwan for quite a long time, and it is based on RFA. Now there's another company called Creo, which is a British company, that has replaced RFA with a microwave, and this is also used for tumor ablation. It's a 19-gauge needle, and you can pass it successfully in the stomach. With the duodenum, it could be a little challenge because of decreased flexibility. And the advantage of a microwave is that it's supposed to cause deeper tissue injury, and it's not controlled by a feedback mechanism. So you have to be a little careful. You can overburn the normal pancreas. We don't have any data about this new technology. Time will tell. But I think before we focus too much on tumor ablation, we have to look back at the type of data that we have at present. There are only 19 studies on EU-guided RFA looking at 183 patients around the world. And there are two kinds of neuroendocrine tumors. One is the functional tumor, which is an insulinoma. The efficacy is about 95%. So, this is on short-term follow-up. Adverse events is about 18%. The most common is pancreatitis. But the problem is, in these 16 reports, 5 out of these 16 reports had literally one patient. And in 10 out of 16 studies, the follow-up is less than 1 year. So you're looking at very, very limited data, and developing products with such limited data can be a problem. If you're looking at non-functional neuroendocrine tumors, most patients are asymptomatic. You treat them only if they are symptomatic. And the treatment efficacy is 95%. The adverse events are about 25%. Once again, it's pancreatitis is a primary problem. And if you follow these patients for a longer time, the tumor will increase in size. So we don't have long-term data on what happens beyond a year. Once more, in 50% of the reports, they had only one patient, and in 2/3, the follow-up is less than a year. And then you got something like this, where they tell you, your treatment actually with these thermal devices is better when a tumor is less than 2 centimeters. But if you go and look at the oncology literature, tumors less than 2 centimeters don't require treatment unless they are functional. You shouldn't be treating them at all. So I think we are focusing a lot on these devices, looking at very small patients, and this is data collected from the whole of Europe. So if you're looking at 183 patients across 20 countries over 10 years, and this is all retrospective, we have got some problems. The other issue that we are now focusing on is pancreatic cyst, and it's just because we have got so many patients with pancreatic cyst. We used to ablate them with alcohol, but now they use paclitaxel and gemcitabine, and it has been shown you get an equal treatment success rate of like 67% with almost zero complications. With alcohol, you got 22% complications. And when these 67% of the patients are followed up for a prolonged period of time, there's about a 90% durable response. At the surface, this looks pretty good. And then you've got publications like this. You're looking at 1,077 patients, and when you look at these patients with an average age of more than 50, and you do a CT scan or a MRI, 50% of them will have a cyst in the pancreas. You follow them for 5 years, 15% will develop a new cyst, and these cysts will increase over time. And if you look at those 1,077 patients over a 5-year period, not a single patient dies of pancreatic cancer. So we do 3,000 EUs in Florida a year, out of which 1,000 are for pancreatic cysts. I did a simple math, and I realized over 5 years we would be spending only in our own center close to $40 million for zero mortality from these pancreatic cysts. But we get increased referrals, and patients want their pancreas to be checked because there's a phobia for pancreatic cancer. So I think our energy should be more directed towards studying the natural biology of pancreatic cysts than to treat these asymptomatic lesions. So this was one of my talks for DDW for state of the art. I think we just need the wisdom to choose the battle that we need to fight. Endohepatology is a hot topic, and I think this is one area surprisingly the hepatologists are encouraging us, not for liver biopsies, but for portal pressure measurements. They tell us that when they refer patients to interventional radiology, they get wedge pressure, whereas with EUS, we can directly get a portal pressure. And in this particular case, this is the portal vein, the intrahepatic vein, which is very easy to target. And then you puncture it with a 25-gauge needle. This is a transducer from Cook, and you will draw a pressure measurement. And then you retract that needle after an average of 3, and then you puncture the portal vein, and then you calculate the difference. And if it is more than 7, the portal, it's supposed to be positive for portal hypertension. It's a simple procedure to perform. It takes about 10 minutes. The patient should be done under general anesthesia, not under propofol. But otherwise, it's pretty straightforward. And when we do this, we are usually asked to do a liver biopsy at the same time, just because you don't have to repeat this procedure again. But unfortunately, in the United States, I think there are 2 things happening. When you do portal pressures, it's great. You have an added advantage. But we are getting a lot of referrals only for liver biopsies. I think that's, again, a problem because the cost of an EUS guided liver biopsy done with EUS, with sedation in the US, is about $13,000. But if you send them to a radiologist with a percutaneous 16-gauge needle, it's probably about $1,000 because they don't even sedate them. So there's an $11,000 difference, but we get lots of referrals because patients don't want to feel any pain whatsoever. So we're doing a lot of EUS-guided biopsies, and the pathologists don't like it because obviously with 16-gauge needle, you get a larger core tissue, whereas with a 19-gauge needle, it is small. So I would call this as the American problem. Like sphincter of Oddi dysfunction, we are obsessed with the liver biopsies. But there's good data. If you look at portal pressures, 159 patients, there appears to be a very good correlation between more than a 7 millimeter gradient and presence of esophageal varices, hypertensive gastropathy, thrombocytopenia, and then this is, and when you combine it with liver biopsies, this appears to be a good technique. The next topic is gallbladder drainage. Now, this this graph on the left is a very serious graph. So this is the US Medicare database. You're looking at 250,000 patients. So this is real life United States. You can look at the graph in the middle, the curve comes down. This is conversion of open cholecystectomy to laparoscopy, which is good. If you look at the top graph, that is laparoscopic cholecystectomy, it's a stable line. So between the year 2000 to 2010, cholecystectomy, laparoscopic cholecystectomy has gone up by 1.2%. The last graph at the bottom looks very small, but you have to focus on that. That's close to 50,000 procedures. And that has increased by 409%. And this is percutaneous cholecystostomy. So if you go to real United States hospitals, a lot of hospitals, unless the patient is extremely healthy, you come at 1 o'clock at night with pain, you got a little bit of cholangitis, they get a percutaneous cholecystostomy tube. And then they go home, and then they will either have a cholecystectomy at some point if they are very comfortable, or they will get these tubes changed in and out. So I got a patient maybe a couple of months back, and I looked to see when he had his cholecystostomy placed. It was placed August 15th, 1987. So this guy has been having his tubes changed for the last 40 years. So now what we do is EUS-guided gallbladder drainage. So when this patient came, I thought, well, I'm just going to change to an EUS-guided gallbladder drainage. And then I asked my surgeon. He said, no, I can operate on this patient and so on. So EUS-guided gallbladder drainage is a good technique. So this patient has got an emphysematous gallbladder. You can see there, it's coming out. The patient is sick. I can drain this gallbladder. It takes me 10 minutes. But the problem is, if a majority of these can be accessed through the duodenum. So if you put an access through the duodenum, you're converting a cholecystectomy usually into a Whipple procedure because the surgeon tells me that is an area I can't touch. So most of them will never have surgery. They will sit with this thing, and then you go back and you put a plastic stent, and then you start removing stones, you start having complications, and it is no fun working through the duodenum. You put it through the stomach, it's okay, but then you convert a laparoscopic cholecystectomy into your open cholecystectomy, and I never knew it was this difficult because one day I went to the parking garage and I saw this surgeon who was about 55 years old after a lap chole with his head all sweating. And he asked me, he told me, what the hell did you put in the stomach? And my open cholecystectomy of 15 minutes became 2 hours. And surgeons are more and more doing these procedures. I think Boston Scientific is applying for an FDA approval for EUS-guided gallbladder drainage. It will be performed more, but I think we need to take a step back. Yes, we can do it, but are we doing the right thing for the patient? Because at 1 o'clock at night, most patients look as not a surgical candidate because they're sick. And then what you find is that once their sepsis goes down, they're pretty comfortable and you can always do an elective procedure. So this is a multi-dimensional problem. So I would not say a high-risk surgical patient. EUS-guided gallbladder drainage should be done in what I call a never surgery patient, high COPD patient, extensive coronary artery disease, not ready for heart transplant, pancreatic cancer patients with metal stents who develop cholecystitis. I think this is the patient population we should focus on, which will decrease the indication to literally less than 0.1%. Otherwise, this will be an abused technique. And the last is, this is a simple topic, pancreatic necrosis. Of course, if you have an infection, we have got a 20% mortality. But the problem in pancreatic necrosis, once again, is that when you develop severe acute pancreatitis and pancreatic necrosis, most mortality happens within the first 10 days. We don't even see these patients. They've got acute sepsis and they die. They don't have a fluid collection and they are in the ICU. Should they survive that time, then they have the second hit. When they develop infection and they become septic, they develop multi-organ failure, and there's another 10% mortality. If they survive that, then you develop walled-off pancreatic necrosis. That is when we usually intervene, when mortality is significantly less. But we never go and see the patient when they are in their acute phases of illness because they really don't even have a fluid collection or it is ill-defined. So if you look at a time graph, this is your ICU patient within the first 10 days. It's got an ill-defined collection. Nobody wants to put in a drainage catheter, including the radiologist, and this is where maximum death happens. If you wait for 2 weeks or 3 weeks, you've got a collection. It's ill-defined. This is called the acute necrotic collection. I think we can intervene in these patients. There's more and more data, but not robust data. And if you give it time, for 4th week, you've got walled-off necrosis, which is what we treat right now. If you really want to improve outcomes for this patient, we need to be looking at the time frame in the middle, 2 to 3 weeks, what happens there. And if you look at the studies from the Dutch pancreatitis study group, once again, endoscopy is associated with a less pro-inflammatory response and better outcomes for patients. And if you look at Pointer trial, where they have told us there's no advantage in intervening early, but when the Dutch pancreatitis study group tells us early, and you look at their supplemental file, it's usually a third week. It's only at the 3rd week they are putting in a percutaneous catheter. At least in our clinical practice, we are now intervening between the 2 and the 3 week time frame. So I strongly believe that if a patient is very sick and if the patient is very septic and if they are unstable, we should be able to intervene in this time frame, because if you don't do anything, they have a 25% mortality. If you do something, maybe we will have a good outcome and we can make a meaningful difference. So I think we will see a lot of research going into this area. Also, percutaneous drainage catheters, it is not published data, but when we look at the Medicare database, we realized percutaneous catheters are an independent predictor of mortality. I never realized it. So this is new data that we are hoping to get published, looking at tens of thousands of patients over the last 20 years. So this was my last slide, and then there's another conference. There's a lot of conferences these days. So if you want to step out of Europe, please come to Orlando and see us. Thank you.
Thank you very much for this brilliant lecture. We have learned a lot, and let's hope we can fly to Florida. Are there any questions from the floor? Yes, please.
Thank you very much for this excellent talk, Shyam. I have a couple of questions. The first one is, when you do the edge procedure, I saw you put a suture. Do you do this because you directly use the access immediately, or do you always put a suture and then access a few days later?
So the reason to, if you don't want to suture it, you have to come back after 2 weeks so that the tract is mature. But in the United States, you'll be out of business. I mean, our patients expect things to be done then and there. And if they come with jaundice, they want a tissue diagnosis, they want their procedure the same day. So that is the reason to suture it. If you don't suture it, the stent will almost always migrate. Almost always. And then there is, if it migrates into the retroperitoneal cavity, then you need to have a laparoscopic surgery at that point. So that's the reason we suture at the same time.
Okay. The second question was regarding the peripancreatic collections. When you do early drainage, do you always use axios lambs, for such procedures, or?
Of course. Okay. It's only $5,500. Yeah, we always use lambs. That's the only one that's approved in the United States. But I don't think anyone in the United States anymore uses plastic stents. In fact, people have forgotten how to do plastics, how to use drainage with plastic. So it's always lamps.
Thank you.
Shyam, thank you
My
for
pleasure.
this fantastic presentation for the moment. I think you explained very well. We experienced somehow an explosion of non-indicated niche indications. And my question to you is, you talked about the problem of pancreatic cysts. And thank you for citing the German study. What do you think, how do you see this in the future? I think you mentioned that almost this cyst follow-up collapses our healthcare system. What, when do you see an indication to treat endoscopically with alcohol or anything else, such a cyst in the pancreas?
I mean, I think the problem is we are approaching pancreatic cyst with the eyes of an endoscopist, and I think that is the problem. There are four issues here. Low risk cyst, low risk patient. Don't do anything. Low risk cyst, high risk patient. There's no point doing anything. High risk cyst, high risk patient. They're going to die. Don't do anything. High risk cyst, low risk patient. So if you stratify, the 1,000 patients come down to literally 100. You've got a 50-year-old patient with a 3.5 centimeter cyst on the pancreas with a large mural nodule. You need to operate. Guess what happens? You don't have competent surgeons. So they will look at it and say, well, let's get another EUS in 6 months. Let us know what happens. You keep following this guy at age 69. Now he's got a 5 centimeter cyst with a high-grade dysplasia, and he will not get surgery. So one of the advantages of Europe is that you have concentrated your outcomes to few specialized centers. Maybe, maybe not. But for us, we have a surgeon in every hospital who claims they can do a Whipple. So, and healthcare systems do not reward us for sending patients to other campuses. We have to preserve them within the system. So this is the problem. The only way we can overcome this problem is to look at the biology of the cyst and risk stratify. Then I think we will do what is right. As I've told you, Stefan, my math tells me in the year 2025, the state of Florida will spend $56 billion on surveillance of pancreatic cysts. And if you translate that, only 5 patients will require a curative Whipple procedure.
But the problems are the guidelines, because I think there are 4 societies for guidelines, and when you look in, you get shocked because you have to follow up either MRI or EOS every 6 to 12 months. So how can we approach this problem with the guidelines?
I don't think guidelines. I think what we need is a longitudinal follow-up after baseline good characterization, and just chill out for 10 years and collect the data and find out what happens to which patient. Then I think we'll get an answer. Until we don't know what is happening with the pancreatic cyst, we are like blind people trying to figure out how an elephant looks.
Sure. Thank you for this outstanding lecture, and we have now a coffee break of 30 minutes, and I'm looking forward to see you back. Thank you.
Fujifilm is a pioneer in diagnostic imaging. With over 70 years of expertise, we put cutting-edge tools in our customers' hands so patients get excellent results. Now we introduce Eluxio Ultra. Eluxio Ultra enhances your existing Eluxio platform by incorporating CAD-I, our powerful AI technology. With CAD-I, Eluxio Ultra is one of the first endoscopy solutions to detect and characterize lesions in real time, delivering our most powerful, complete, and comprehensive package for endoscopists. Eluxio Ultra will accommodate a range of future tools and technologies as they evolve, so our best endoscopy system for your patients today will remain so tomorrow. Human instinct plus artificial intelligence equals Eluxio Ultra, now available for your practice. Fujifilm is a pioneer in diagnostic imaging. With over 70 years of expertise, we put cutting-edge tools in our customers' hands so patients get excellent results. Now we introduce Eluxio Ultra. Eluxio Ultra enhances your existing Eluxio platform by incorporating CAD-I, our powerful AI technology. With CAD-I, Eluxio Ultra is one of the first endoscopy solutions to detect and characterize lesions in real time, delivering our most powerful, complete, and comprehensive package for endoscopists. Eluxio Ultra will accommodate a range of future tools and technologies as they evolve, so our best endoscopy system for your patients today will remain so tomorrow. Human instinct plus artificial intelligence equals Eluxio Ultra, now available for your practice. Fujifilm is a pioneer in diagnostic imaging. With over 70 years of expertise, we put cutting-edge tools in our customers' hands so patients get excellent results. Now we introduce Eluxio Ultra. Eluxio Ultra enhances your existing Eluxio platform by incorporating CAD-I, our powerful AI technology. With CAD-I, Eluxio Ultra is one of the first endoscopy solutions to detect and characterize lesions in real time, delivering our most powerful, complete, and comprehensive package for endoscopists. Eluxio Ultra will accommodate a range of future tools and technologies as they evolve, so our best endoscopy system for your patients today will remain so tomorrow. Human instinct plus artificial intelligence equals Eluxio Ultra, now available for your practice.
Colleagues, it is now my great honor to welcome Professor Naohisa Yahagi. He's Professor of Medicine, Director of the Division of Research and Development for Minimally Invasive Treatment, Cancer Center, Keio University, School of Medicine in Tokyo, and he is one of the pioneers of endoscopic submucosal dissection. This technique has been tremendously perfectionized in the past years, and it looks that we can go deeper than only to the submucosa. And I'm looking now forward to your presentation, Deeper Dissection to Remove Challenging Colorectal Lesions. Naohisa, please.
Thank you very much, Stefan, for your kind introduction, and I very much appreciate you for your kindness to invite me again to this wonderful EndoSwiss meeting. It's always a great pleasure for me being here. Today, I would like to talk about a little bit crazy procedure, which is deeper dissection to remove challenging lesions, not only in the rectum, but also in the colon. This is my COI to disclose. Well, the most challenging situation for endoscopic resection is severe fibrosis. Sometimes severe fibrosis is caused by previous endoscopic attempt, or sometimes caused by muscle traction because of the movement of big polypoid lesion, and sometimes caused by surgical staples. All these regions are very difficult situation to do endoscopic resection because we cannot open the submucosal space enough and we cannot find the right dissection plane. But by dissecting a little bit deeper part, sometimes cutting through the muscle layer or even outside the colon, still it's possible to remove those kind of lesions. I would like to share some of my treated cases. Well, this is a remnant lesion after partial mucosal resection. Because of the perforation, the treatment was discontinued at the other institution. And this patient coming to our unit to avoid unnecessary surgery. And because the previous resected specimen showed just a benign adenoma, we decided to remove this region by full thickness resection. I did this procedure nearly 20 years ago. It was like a crazy procedure. Of course, there was no available specific device for closure. Therefore, I simply used the loop snare and end clips and completely sutured after complete resection of this region. Fortunately, clinical course was quite good. There was no severe pain, no fever, and this patient discharged from the hospital 2 days after the treatment. And unfortunately, this region already became mucosal cancer, although we achieved curative resection. I was a little bit afraid of cancer cell seeding because of the cancerous component. Fortunately, nothing happened after the treatment, but we should think about the risk of cancer cell seedings when we conduct full thickness resection. Well, this is another example of difficult case, which is a really large region located at the lower rectum. It was starting just above the anal canal and extended more than 2/3 of the circumference. And because of the presence of big polypoid lesion, movement of this kind of big polypoid lesion induces a lot of fibrosis and sometimes causes muscle traction. That is the really big challenge for us. And of course, this kind of big lesion always accompany rich vascular network within the submucosal layer. Therefore, management of bleeding during ESD procedure is extremely important for us. Most of the tiny bleeding coming from the minor blood vessel can be easily managed by closed tip of dual knife. And of course, we should use coagrasper for the active bleeding from the artery. But I really prefer to seal the sick blood vessel when we find out the sick blood vessel. I just use open tip dual knife and apply very low setting of forced coag, which is 0.3 of bio3. We can easily abrade and seal the sick blood vessel with this technique. It is really effective. And the most challenging part for this procedure is muscle traction. Important technical tip to overcome this difficult situation is to expose the traction area, tracted area. Then we can cut through the muscle layer itself. Actually, I cut through the muscle layer, and sometimes we encounter serious bleeding because of the presence of thick artery, but still we can control it by using RDI and coagrasper. And finally, I achieved complete resection. Surprisingly, it was just a mucosal cancer, even though the lesion size was quite big, which was more than 10 centimeters. So this was the beauty of endoscopic resection, and of course, clinical course was quite favorable. There was no stricture formation at all, even though resected area was more than nearly 80% of the circumference. Well, as I mentioned, most of the fibrotic lesion is very tough to do ESD because of the difficulty of opening the submucosal space, visualizing the submucosal layer. That's why I developed a new technique, which is water pressure method. By immersing the entire lesion with the normal cell line, then attaching the ST food, which was developed by Professor Yamamoto, I always flush the normal cell line to the inside the area. As an active pressure of normal cell line, we can easily open the submucosal space, then visualize the submucosal layer or fibrotic area. Well, this is also a challenging case, which is semi-pedunculated lesion located at the sigmoid column. It looks like invasive cancer because of the muscle traction sign, but taken biopsy revealed just a benign adenoma, although some of the taken biopsy were suspicious of adenocarcinoma, but this patient refused surgery. That's why my surgical colleague asked me to do endoscopic resection. So it was really challenging case because of the muscle traction sign, and there was a tattoo very close to the target area. So I immersed the entire lesion with a normal cell line and injected a little bit large amount of glycerol solution to the submucosal layer, and there was a remarkable non-lifting sign, but it doesn't matter. I opened the submucosal space and quickly dissected this surrounding tissue in order to visualize the fibrotic area. Now we can see the muscle traction sign here, and again, carefully cut through this fibrotic area using cutting current. It was quite smooth because there was no vascular network within the fibrosis. Then I could open the fibrosis relatively easy. Now we can see the opposite side through the fibrosis. And again, hooking the remaining fibrosis, I could complete the dissection of the fibrotic area. As a result, it turns to a nice and easy situation. Then I completed the circumferential mucosal incision by using a dry cut, then quickly resumed the submucosal dissection. As a result of giving active pressure to the remaining submucosal layer, it becomes a really easy situation. I could visualize the rest of the remaining submucosa, and this is the final result. Well, this was completely removed, but unfortunately, this was actually deeply invasive cancer and also had lymph vascular infiltration. Therefore, finally, this patient accepted surgery. Several years ago, Dr. Toyonaga and Kobe University group proposed a new concept, which is anal endoscopic myectomy. This is really aggressive concept because we should cut through in between inner circular muscle and the outer longitudinal muscle. But as a result of removing entire lesion in an unblocked fashion with margin-free fashion, we can observe the clinical cause if this lesion doesn't have lymph vascular infiltration. This is one of the good concepts, especially for the elderly patient who already have some underlying diseases. I would like to show you some of this kind of example. This is a relatively flat lesion located at the lower rectum, but if we look at this area very carefully, we can recognize the irregularity of the surface at the depressed area. And by using NBI and magnification, we recognize the avascular area, which suggests a deep submucosal invasion. That's why we conducted EUS and find the deeply invasive part also by EUS. That's why we asked this patient to go for surgery, but this patient strongly desired to have endoscopic resection because this patient was suffering from diabetes mellitus and diabetic nephropathy and coronary heart disease. That's why my young colleague decided to do ESD as diagnostic purpose, and if we could achieve complete margin-free resection, and if there is no lymph vascular infiltration, we imagine that we could observe the clinical cause without giving additional surgery. Now, we made an initial mucosal incision at the oral side at the in a retroflex position, then move back to the straight position and extended the mucosal incision to the lateral side and trace the incision line using coagulation current to dilate the opening of the submucosal layer, which is very important to recognize the endpoint of the submucosal dissection. Then move back to the anal side and injected a little bit larger amount of solution to the submucosal layer and quickly extend the mucosal incision and connect to the oral side. And again, made a mucosal incision also on the left side and completed the circumferential mucosal incision. Then, by using the water pressure method, we could easily visualize the submucosal layer. And the initial part was quite easy because there was no severe fibrosis, therefore it went very smoothly. We can easily open the submucosal space by flushing the normal cell lines through the endoscope. And my young colleague tried to dissect the deeper part of the submucosal layer to avoid vertical margin-free positive resection. And if it is necessary, we injected additional solutions through the knife. It makes it much easier to recognize the true dissection plane. And it was quite smooth until the middle of the procedure, but we found that this very thick blood vessel at the middle of the tumor. That's why we applied 0.3 of forced coag and completely sealed the vessel, then cut through the bundle of the blood vessel. And after cutting here, we found some fibrosis probably caused by the desmoplastic reaction of the tumor. That's why we go to the muscle layer and intentionally dissect in between inner sacral muscle and outer longitudinal muscle. We can visualize the muscle layer itself and carefully conducted deep dissection in this particular case. Of course, we should avoid complete perforation. This was invasive cancer, so we carefully visualize the muscle layer and cut through in between the inner muscle and outer muscle. Then this is almost the end of the muscular dissection, and by injecting blue colored solution to the surrounding submucosal layer, we could easily recognize the light dissection plane. After cutting through the muscle layer, it becomes standard situation, just dissecting the remaining submucosal tissue using dual knife and glycerol solution. It went very smoothly for the rest of the procedure. This is almost the end of the submucosal dissection, and quickly finished the procedure. So this region was completely removed intramuscular dissection. Now we can see the muscle attachment at the lower behind the resected specimen, and this is the resection bed. As you can see here, there was partial muscle defect on the surface of the large mucosal defect. In order to make sure the safety after the complete resection, my colleague closed the mucosal muscle defect side first using a sure clip in order to keep the safety. But our intention is to close the large mucosal defect at the end. Therefore, by hooking the muscle hold and bring it to the anal side and oral side, then clip it to the mucosal edge. It was quite easy because size of the wound becomes quite smaller after holding the muscle layer. Then it becomes possible to close the large mucosal defect by applying additional clips. Finally, we bring the proximal mucosal edge to the distal edge and close it completely. And with additional a few endo clips, finally we closed this large defect. We recently published this technique as origami method. In this technique, we intentionally catch the middle of the muscle layer in order to make the small hole within the muscle layer and bring it to the anal side, or bring back to the bring it to the oral side, and or bring back to the anal side by hooking the muscle hold with the endo clip. This is quite effective and very simple technique because we are just using through the scope endo clips. Actually, this case was completely closed, but again, unfortunately, this region already had lymph vascular infiltration, and finally, this patient also agreed for surgery. This kind of situation often happens. For the mucosal closure, I developed another special technique, which is string clip suturing method. In this technique, I usually introduce clip and line together through the working channel and approach to the oral side first, distal side first, and intentionally capture both part of the muscle layer and part of the mucosal layer. Because if we catch only the mucosal layer, closure becomes superficial. As a result, it creates the submucosal pocket. It's not a good situation. Therefore, I usually intentionally capture both part of the muscle layer and part of the surrounding mucosa. As a result, by pulling the string, we can easily approximate large opening. Then closure of the large defect using additional end clip becomes quite easy. After closing to some amount, I can easily cut the line using scissors forceps from Olympus, then apply the second end clip and line, and also close the large defect on the right side. By pulling the string, it becomes quite easy situation to close it by additional end clips. In this way, we can close large mucosal defect, not only in the colon, but also in the duodenum. I'm sorry showing the duodenal case, but particularly in the duodenum, complete closure is quite important to avoid the delayed complication. Well, most challenging situation is lesion arising on the anastomosis side. This patient was longly suffering from familial adenomatosis pulposus. Therefore, this patient already had the colectomy with ileal pouch reconstruction. And unfortunately, this laterally spreading tumor arising from the anastomosis side. This is the most challenging situation, but by using the water pressure method, we can open the submucosal space, and by hooking the surgical staple with the tip of ESD device and using endocut, we can easily remove this kind of surgical staples. As a result, we could achieve complete resection of this tumor. Fortunately, this was just a benign adenoma, therefore, we avoided unnecessary surgery in this particular case. Well, I think deeper dissection is quite effective even for the challenging situation, but still it's really controversial concept because it has both risk and benefit. Most important benefit of this technique is potential to avoid unnecessary surgery. As a result, we can preserve GI function. But as I already mentioned, most of the invasive cancer usually have lymph vascular infiltration, which is a high-risk situation. Therefore, we should carefully select the target lesion. And of course, we should avoid full thickness resection for the actual invasive cancer. And usually, deep dissection is extremely challenging and sometimes risky. Therefore, we should think about a balance between risk and benefit, and we should avoid potential risk of cancer cell seeding after perforation. Well, this is my conclusion. Deep dissection is sometimes very useful, especially for elderly population who already have some underlying diseases, but we should completely close the large mucosal defect after the resection. And of course, we should think about the balance between risk and the benefit of the procedure. Thank you very much for your kind attention.
Thank you now, Hisa, for this outstanding lecture. So if I understand you correctly, so we can not only go deeper in the rectum, but also in the upper colon, but only with water. Water is the key for the success.
I think so.
Mm-hmm. I have another question. In the past, when you visited us, we collected all the large adenoma, and then after some times of resection, we had to talk the patient because of the conditions of the gravity, sometimes to the left side, sometimes to the right side. Is this now the past with this new underwater method? Or?
For the water pressure method, we don't have to care about the direction of the gravity. We should care about the smooth control of the endoscope. Therefore, we check the maneuverability of the endoscope, then we can complete the procedure by using the water pressure method. We don't have to change the patient position.
Please, microphone.
Thank you for your impressive demonstration. In this context, it would be interesting to know if the invasion depth of 1,000 micron for submucosal invasion, is it still considered as an independent risk factor in Japan, or will the guidelines be changed?
Previously, we thought that 1,000 micrometer is a kind of critical parameter which suggests risk for lymph node metastasis. But as a result of accumulating a lot of clinical cases, so we found that the simple invasion depth is not a risk factor. If there is vascular infiltration, it's certainly a risk factor. But as a result of prospective study of the Japanese society, we again found that 2,000 micrometer is the threshold which demonstrate the risk of lymph node metastasis. But our guideline will be changed up to 2,000 micron for the submucosal invasion in the near future.
I have another question, if I understood you correctly. So your intention is always, even you went deeper, you close the defect. Do you do this also always in the rectum, or do you keep the wound open in the rectum?
I always try to close the opening all the time.
And another question, I think this is also in the discussion now. I think in Amsterdam there's a study about this endoscopic intermuscular dissection. If you have the histological result of lymphovascular invasion, what is your strategy in these patients?
I always recommend to do surgery to avoid future lymph node metastasis or distant metastasis. But it depends on the patient condition.
Okay, thank you very much. Yeah.
So now I want to introduce a very good friend of mine. Remus Frey is a deputy lead of our endoscopy unit in St. Gallen. He's also senior lecturer at the medical school of the University of St. Gallen. And he leads the endoscopy group of Switzerland and is one of the main contributors to the expert opinion statements. So Remus, the floor is yours, and we're happy to have you here. Thank you.
Thank you very much, Jan, for this kind introduction. And Stefan, thank you very much for the invitation to this exceptional symposium. Thank you very much. So I will talk about endoscopic vacuum therapy, EVT, or endoluminal vacuum therapy in the next 25 minutes. What is the background? The background is that esophageal perforations and anastomotic leakage, especially after upper GI surgery, lead to a high morbidity and mortality. And we know from a bit of data probably that EVT has emerged as a useful tool with high efficacy. And from human and animal studies, we know that the negative pressure therapy contracts wound edges, removes exudate, including inflammatory and infectious material. We see this when we change the sponges. It promotes angiogenesis and it stimulates tissue granulation. These are all facts that perfect healing needs, and the negative pressure therapy promotes these factors. And so we get data for success rates of about 80 till about 90% for vacuum therapy in these patients. But those who fail, 10 to 20%, what do we do with this? And I will present and share with you a case where endoscopic therapy actually failed. And we'll probably ask, why did it fail in this patient? This is the patient. He is not yet 50 years old, and he was diagnosed cancer of the GE junction, a T3 tumor, nodal positive, and he was treated in a curative intention with neoadjuvant radiochemotherapy. You see the regimen. And he was operated with a roboter-assisted minimal invasive esophagectomy at the end of February. And it's also important to mention the timeline. These patients with these complications that we discuss now, they are a very long time in hospital, they are very sick, and they have a lot of complications. So the definite histology of the tumor was YPT3, YPN2, L1. So a high-risk situation for recurrence after surgery. Everything went fine till 2 weeks. He was in hospital, and then he developed fever and a rise in CRP. And we did a gastroscopy, and what we saw, you see it on the left picture, you see a leak on the right upper quadrant. And what we first did is we inserted the EsoSponge for endoscopic vacuum therapy. What is EsoSponge? For those who are not very familiar with this therapy, I show how this works. So on the left picture, you see how the EsoSponge comes. It's an overtube. It's a pusher. So you place the sponge through this overtube, via this overtube with the pusher. Then you see the sponge with the sucking catheter, and there is a device to connect the vacuum pump. You usually have to cut the sponge a little bit so that it can be easily pushed through the overtube, so it makes it easier to position it correctly. And after the positioning, you attach the vacuum pump with usually a continuous suction of 125 millimeters of mercury. Usually change it every 3 days. What is data that we have on this therapy? And this is a study, Endoscopy 2023. And Stefan, you also took part of the study. 27 patients with iatrogenic perforations, Perhave, and 2 trauma. And a very high success rate of 89%. And what you see is the median number of sponge exchanges low, was 1, but the median duration of EVT in days was 12 days. Failure, 3 patients. And we will have quite a straight look at these patients who failed. What was the problem there? EVT failed in 3. This is what I mentioned before. One patient died due to a septic embolic stroke. So a complication of the complication. One died due to pulmonary embolism, the one that 4 and the other 14 days after the negative pressure therapy. And one underwent esophagectomy because the defect showed no improvement under therapy. And this patient, as I read, had quite a long delay until the defect was recognized and then treated. And delay seems to be an important factor for success or not. And one patient died 8 days after completion of successful EVT, most likely to a cardiac cause. So these patients who have esophageal cancer and resection, they usually not have this alone, but they have comorbidity. This is the largest series that was presented at the ESGE days. It comes from the Spanish multi-center register. And it was presented at the ESGE days in spring in Dublin. And I present these data here. 102 patients, indications, surgery, obesity surgery, you see it here, Perhave, endoscopic perforation, Senker, diverticulotomy, and some others. The location, the main is thoracic or abdominal, some cervical. Prior therapies, resurgery, fully covered metal stent, and clips in 3 patients. What are the results? Closure of the defect, 84%. That's what we saw in the other study as well. So a little bit more than 80%. And we see a difference between perforations and anastomotic leakage after surgery. And there seemed to be a difference. This seemed to be a different population. And what I also want to mention is this fatal bleeding of an aortoesophageal fistula. So we have to be aware that when we place the stent extraluminal in a cavity, when there is a large defect and we have to place the stent in a cavity, we have to make sure afterwards where the sponge is definitely placed. Because endoscopically, we can hardly say where we are. If we go into the defect, we go into the mediastinum, we hardly can say where we are. That's why if we have to place a sponge out of the lumen, we usually make a CT scan. At least the first time we put the stent there to make sure where the sponge actually is. And so we can probably avoid this this complication, because when you suck the aorta, this will be a fatal complication. What did we do with our patient? We had a problem. As we wanted to apply the negative pressure, it was impossible. We couldn't get any negative pressure. Why? The CT showed why. We had a fistula. And we had actually a fistula, you see it here, from the esophagus to the main right bronchus. That's why we sucked the air from from the airway, but we couldn't get any negative pressure. You see it here, the fistula, and you see here the defect. What did we do? We put it a fully covered metal stent to seal the fistula. What does the data say about that? This is the updated ESGE guideline, the guideline of our European Society of Endoscopy, how we should proceed. And it said, recommends temporary stent placement can be considered for the treatment of leaks, fistula, and perforations. Strong recommendations, low quality of evidence. And what it also says is that the treatment should start as early as possible. So don't give any delay. So if you see it, treat it. Or if you recognize it, treat it. So strong recommendation, but very few data, obviously. And I searched for the data. What is the data? And I found this review. Stents in the treatment of leaks and esophageal perforations, systematic review. 66 studies, 1,700 patients. Success rate high, almost as high as with the sponge, which I could hardly believe. Multivariate analysis showed lower rates of clinical success in patients who had fistula and an orifice size of over 2 centimeters, which means if we have a large defect or we have a fistula, the therapy seems to be less effective. And then I wanted to know how many patients actually had a fistula. I couldn't find out. Then I searched for more data consisting with our problem with fistula. And just a little bit for this, for the stent therapy. The technical success here. And what I wanted to focus with this is the migration rates, 16%. This is what we know from the stent therapy, from the fully covered metal stents anyways. So the stent, they migrate, and they have a lot of re-interventions. So that's what we know from stenting with fully covered metal stents in other situations as well. This study focused on tracheobronchial fistula after esophageal resection. The study is 10 years old, but this is the largest series that I found, actually. And there were 222 patients. They were operated for esophageal cancer, and 7 of them, 3%, they developed fistula to the airway fistula. 4 of them had endoscopic stent implantation. 2 had surgical re-exploration because the fistula was accompanied by necrosis, which couldn't be handled conservatively. Closure of the fistula was achieved in all cases, and 1 patient died due to respiratory failure. So if we count these patients, we get of less than 50% that were saved by actually stenting. So this is the data that I found. How did it go on? So we wanted to remove the stent after 6 weeks. The ESGE guideline doesn't give us a straight guideline. How long do we have to stent? But we know that 6 to 8 weeks is probably the right time to remove. Everything fine. ZRP, low. Patient in good conditions. CT scan, you see it on the left. The fistula has gone. So everything fine. Probably not. As I introduced in the introduction, we were not actually successful with the treatment. And this is how it looked like after stent removal. You see here the fistula that we treated from the beginning. It didn't change at all. And if you look through the fistula, you can straightly see on the right main bronchus. What did we do? These patients are extremely complex, and I want to show this with this picture, with this image on the left-hand side. So we made a rendezvous, pneumology, gastroenterology. So from the pneumology side, they put in an airway stent, a Y stent, to cover the fistula from the airway side. And we put it a stent. You see the picture on below. You can see the airway stent through the fistula from the esophageal side. Then we put the sponge, and we changed it every 3 days, as we usually do. What happened? Almost nothing. And we had the problem to actually keep the negative pressure, because depending on the position of the patient, the stent, of the airway stent, could actually close the fistula, and in another position not. And so it was impossible to get a continuous negative pressure. This was probably the problem, or one of the problems here. So not effective. How did we proceed? We put this new kit on the block, which is this Vox stent. And the Vox stent, I show you afterwards, is an over-the-wire stent, a fully covered stent system that is positioned like a normal fully covered metal stent. And on the right-hand side, you see after we deployed the stent, you can see the endoscopic control of the correct position of the stent. And you also see the blue, this is the sucking catheter, where you apply also continuous pressure from 75 to 125 millimeters of mercury. These are details of the stent. For those who are not familiar with it, the stent comes in a box like this. It's an over-wire system. You use a 0035 guide wire, and it's quite a large diameter. The tip of the stent has 40 millimeter diameter, and this is the stent. The total length is 70 millimeter. The diameter of the stent itself is 14. The length of the sponge is 5, and the tulip is 30 millimeters. A technical detail is that you have to put a lot of water when you insert and when you want to deploy the stent. Otherwise, it's hard to deploy the stent. So you have to get another. It's just a technical trick. And then you get the continuous negative pressure, as I mentioned, and you change it every 5 to 7 days. Very important, patients can eat and drink. And this is very important, especially for our patients. They are like in hospital for 3 months. And this gets a mental problem for a lot of these patients. So mental health is a question for them. And eating and drinking, they helps them to keep to stick to the therapy. Vox stent in the treatment of esophageal leaks. This is a very recent study. A few patients only, 15 at 3 centers, a total of 41 Vox stents were actually placed in 15 patients, and the leak healing rate of 80%. So a number that we know from the sponge therapy as well. Septic episodes were prevented in 93%, which means that 1 patient had a septic complication, and there was no mortality. 1 anastomotic stenosis was seen during follow-up. And what I want to focus on in this study is the oral intake of liquids. Almost 90% of the patients, they could have oral intake, at least of fluids, which is very important for these patients. And intake of solid food, at least half of the patients, they could eat, which helps them to stick to the therapy, to be mentally healthy in this long period, which is very heavy for this. So, what did we recognize when we changed the stent? It was not that what we expected, or not what we expected. This is the course after 1, 2, and 3 changes of the sponge. There was actually a novel fistula at the tracheal side, so proximal to the first fistula. You see here on the left-hand side, this is the airway stent, so the main duct of the airway stent to the fistula to the trachea. And here you see the fistula we treated from the beginning. So we had actually progressive fistulizing disease after or under therapy with sponge and stent. So it didn't work. And this patient will have to go for surgery in the next days. What can we do? Can preemptive use of such a negative pressure therapy, could this be an option? This is a study that I found in the Annals of Surgery. Retrospective analysis of 67 patients, almost all, 85% were high-risk patients. You see it there. Healing, direct healing, 37% after 1 course of sponge. Prolonged EVT, Again, healing in 13 patients. One uncontained leak with proximal gastric necrosis had to go for surgery. And the overall leak rate was 7.5%, which is low for these patients. And they compared it to a benchmark, cohort which have not had endoscopic vacuum therapy. So this is a cohort where benchmarks were defined. And in this benchmark cohort, the anastomotic leakage rate was 16%. So it could be dramatically reduced through a preemptive use or prophylactic use of a sponge which was placed during the operation, during the resection. In conclusion, endoscopic or endoluminal vacuum therapy seems to be very effective in treating leaks and perforations. In the upper GI tract, that's what I showed. I didn't give you the data about the lower GI tract, but in the lower GI tract, the data are very comparable to those in the upper GI tract. The VacStent is a new kid on the block, enables oral food intake, and this is very important for these patients, that they can even drink, or at least drink, or even eat a little bit. Limits: large leaks, fistula to the airway. These are very complex patients, and they need an individual approach. Cave, delay. It seems to be true that the delay, as longer as we wait, or as we recognize the defect, and the later we treat it, the worse the outcome is. And the preemptive use can be helpful in high-risk patients. And with that, I thank you very much for your kind invitation. And as others said, I would like to invite you kindly to St. Gallen, which is also a beautiful place and not that far away from here. And we have a beautiful symposium, not as beautiful as yours, Stefan, but it's also beautiful. And covering different aspects of hepatology, IBD, and of course endoscopy, and at the end of October. So you're warmly welcome there. Thank you very much for your attention.
Thank you, Ramos, for this invitation. I agreed already. And thank you also for this outstanding presentation. I think I loved your approach to look for the unsuccessful cases. These are very difficult patients, and also to present us such a disaster case. What we have to admit is that we can say that the endoscopic vacuum therapy is in general a game changer. So it is already a life-saving therapy, but for sure there are still very complicated situations. My question to you is, what is your approach now? We have the sponge available, we have the VacStent. The VacStent is relatively expensive. So what is the indication for the moment for you to use the VacStent?
So if we have an indication like I discussed, so our primary therapy is the sponge. The standard in our hospital for such patients, when they get the trimodal therapy, so they are treated radiochemotherapy, they get resection, and the high-risk patients, we do the intraoperative placement of the sponge already. This is not standard, this is for the high-risk patients. For all other patients, we do a jejunocat at the same time of the surgery, and we put a nasogastric sonde just to put away the pressure from the stomach and also from the anastomosis. Because pressure means there is not a good perfusion at the anastomosis, and perfusion is probably the most important point to have healing at the anastomosis. So that's what we do standardly. If we have a problem, then we try to get them early. And then our first approach is to put a sponge. And if we are not successful, as I showed in our patient, after 2 or 3 sponges, we see that it doesn't go into the right direction, then we put the stent, actually. This is so how we approach it.
I think what you also showed Nicely in your presentation that we have not enough data, and I'm very grateful to Jacques' group who started now with prospective trials, and tomorrow I want to admit this, there is the Young Talent Award, and Lisanne Patinama will also show her the results about the preemptive wax stent placement to prevent anastomotic leakages. So this is for tomorrow. Thank you very much, and congratulations for this outstanding presentation. So we have heard now a lot of innovations in endoscopy, and I think what we can say already that the bigger the better is not always good, and an important question is always how can we implement innovations into our daily clinical practice. Many things are healthcare driven. We have heard this from Shyam, and there are questions, do we have enough resources? Is every innovation necessary? So there are a lot of critical questions, and I'm very happy that Jacques Bergmann, who is professor for gastrointestinal endoscopy and head of endoscopy of the University Medical Center in Amsterdam and leader of the esophageal research team, will answer and help us to answer these critical questions. Please, Jacques.
Thank you, Stefan, and hi, Jan, good seeing you. Thank you for being the closure of today's symposium, speaking to you about less is more in endoscopy. Let me start out with a disclaimer. I really enjoy working in endoscopy. I love the technical challenges of interventional endoscopy, and I enjoy in Amsterdam working with the newest of the newest in the field. And I feel privileged if I'm invited to high-quality live courses like this. And most of my professional ego, and to some extent, at least some people tell me most of my personal ego is actually based on what I can do as an endoscopist and as an endoscopic researcher. However, I think it's time to reflect on our endoscopic work. Because we've seen a remarkable increase of what endoscopy can do over the last 30 years, but yet only a modest amount of what we're doing is driven by level 1 evidence. And actually much of our work is based on weak evidence and expert opinion, and a significant part of what we do day in, day out is actually of dubious value to our patients. So what's the message I want to convey in this 25 minutes? The overuse of endoscopy is looming in all your endoscopy lists. And we need to be more aware of what's driving this overutilization. And I think it's time that we work on a less is more attitude in endoscopy. So what's the evidence of endoscopy being overutilized? So here is a study from the United States. It's estimated that about a quarter of all colonoscopies in the US represent overuse. So 50% of Medicare patients with a negative screening colonoscopy will undergo a repeat exam within 7 years. And of patients with 1 or 2 minor polyps, a third has a surveillance exam within 4 years. Crazy Americans? Well, identical study from Italy. Only in the colon, not really. If you look at this meta-analysis from 13,000 upper GI endoscopies, a quarter has inappropriate indications. So it's fair to say that inappropriate exams are common across multiple clinical scenarios, practice settings, and geographic locations. So what drives this? Well, first of all, we and our patients fear of dying of cancer, or we fear of missing out on diagnosing a cancer. And cancer is then generally perceived as a disease that will have a fatal outcome if you just wait and let it go. And dysplasia and polyps, or cancer precursors, or intraepithelial neoplasia, they have the same connotation, not only to our patients, also to us. And everybody knows someone who owes their life to an early detection of cancer. This is the popularity paradox that motivates patients to be screened, or motivates us to screen patients. So look at prostate cancer. This is the most common male cancer. By the age of 80, 60% of men will harbor this cancer, whereas the lifetime risk of dying from metastasized prostate cancer is only 2%. And there's actually no difference in death from prostate cancer if you screen with PSA, with rectal exams, or if you do no screening. And based on these results, the urologists have now adapted a watchful waiting in most patients with asymptomatic prostate cancer. Yet virtually every Da Vinci robot purchased in my country was purchased because of the urologists that wanted to operate on these patients. And we have operated thousands and thousands of these patients for their asymptomatic prostate cancer with complications such as incontinence and impotence. So, cancer, dysplasia, polyps, and cysts, they are not predictions of disease dynamics with an inevitable fatal outcome. They are merely a pathological, or in fact, better to be phrasing it as a morphological description made at a single point in time. And many of these conditions will never progress to cause symptoms or death. So the question becomes, are we dealing with a relevant disease state? And that actually depends on what the precursor is. Is it low grade in the Barrett's? Is it a sessile-serrated polyp in the colon, a hyperplastic polyp, intestinal metaplasia in the antrum? And then the specific progression rate of that entity, and more importantly, the patient's competing risk for mortality. And the conundrum is we don't know how these factors will interact over time. And here we go wrong, because we cannot deal with uncertainty. So we say, treat it and be done with it, and we cannot face an uncertain future outcome. We value doing over waiting. And then another driver is that endoscopists see more, detect more, and strive for overperformance. So the quality of our endoscopies has increased dramatically. So we have HD TV and optical chromoscopy. Our colonoscopes have an image guide and a variable stiffness, so we get to the cecum in a better way. They all have water jet systems, and we have better bowel prep. And then we're training our endoscopists better, and we're using all these quality parameters like ADR. Now that's good, because we will have less lesions missed, but it also increases pretty dramatically the number of patients with irrelevant disease. And the third thing is that we tend to lower the threshold of what we think is a relevant outcome of screening or surveillance. So let's take this is part of my field, it's all about Barrett's. Let's take a moving down the outcome lane for Barrett's land. So the initial goal for Barrett's surveillance is logically to find an invasive cancer in a patient with a life expectancy long enough for that cancer to become a condition that the lesion becomes larger, symptomatic, and that the patient eventually would die. This is what we want to prevent. But if I do an EMR on an 85-year-old, that's highly questionable for a cancer, asymptomatic. It's not that much different from the asymptomatic prostate cancer. The patient will likely die with his cancer instead of from his cancer. And the same holds for RFA for low-grade dysplasia or RFA for non-dysplastic Barrett's. The majority of RFA cases in the United States is actually done for non-dysplastic Barrett's esophagus, moving down the outcome lane as a driver of overutilization of endoscopy. So by inflating the disease reservoir, we intervene at unnecessarily high rates. Another driver has to do that it's, for all of us, way easier to convince a patient to undergo a risky endoscopic procedure than to explain to that patient the whole balance sheet of wait and see. We make money from unnecessary procedures, but we are hardly being paid if we sit down and talk to our patients and not do a procedure. So we want to practice less is more in endoscopy. We're going to spend more time on our patients and making less money. Doing sells, talking sucks. That's the driver. Now, what are the downsides of doing all these unnecessary endoscopies? Well, logically, they're pretty useless to our patients and they increase healthcare costs. It also contributes to the carcinophobia of our society, and they cause harm to our patients. Now, I want to speak to you with the hidden damage of unnecessary endoscopies. So not the directly related complications that we all know. So perforation during a colonoscopy for diagnostic reasons, or a post-EOS FNA pancreatitis. Now I want to speak to you about the bigger, hidden part of the iceberg. So like a CVA after stopping the anticoagulant therapy. Or a patient that at night, preparing for his colonoscopy the next day, stumbles in the toilet and breaks his hip. And the psychological stress and fear of the investigations or the fear of the disease. Far-fetched, too small to be relevant, of dubious causal relation, difficult to measure. Wake up. We underestimate the harmful effects of our unnecessary endoscopies. We all do. So the inconvenient truth here is that we and our patients, we drive this endoscopic overconsumption because we overestimate the risk and the severity of these precancerous conditions. We also overestimate how protective and how positive effect our endoscopies are. And we underestimate the negative effects of our unnecessary endoscopies. So the perceived gain, which drives all of this, is for the few, and that's clearly visible. These are the patients that have their lives saved by these early cancer diagnoses. But the collateral damage is hidden, and that price is paid by all. So can we change that? How do we mitigate this? First of all, we need to raise disease thresholds instead of lowering them. Again, Barrett's land. Don't take a biopsy from a small triangular extension or anything less than 1 centimeter. Lower the threshold for screening. And then only survey if this larger than 1 centimeter extension of Barrett's actually contains intestinal metaplasia, so raise the threshold of surveillance. And only treat low-grade dysplasia if it's confirmed by an expert pathologist and reconfirmed at the second endoscopy. Raise the threshold for treatment. Now, most of these thresholds find their origin in pretty arbitrary decisions made by our guideline committees. And they are generally based on expert opinion only. And there is a frustrating tendency to lower these thresholds over time. So here's a paper published in PLOS over a couple of years ago from the United States, looking at US guidelines over a decade for the 25 most common healthcare conditions like diabetes, hypertension, depression. More than 75% of these new guidelines expanded on the definition of the disease. Best example I could find is this 2018 American Cardiology College and the American Heart Association redefining what hypertension is, lowering the threshold from 140/90 to 130/80. The day after the guideline was published, 31 million healthy Americans suddenly became patients and had hypertension. So then we need to sit down with our guideline committees and speak to them about a less is more strategy. Let's put them in a room for a weekend and say, you can only leave this room if you come out with a new guideline that reduces the endoscopic burden of your disease with 25%. For instance, by incorporating a minimal life expectancy or an upper age limit, like we did for the Barrett's guideline, and which reduced the endoscopic burden with over 40%. So it's doable. And if they object, then you say, well, in God we trust, all others need to show evidence. So provide proof instead of expert opinion if they want to expand on the disease. And I think all these guideline committees should be chaired by an independent clinical epidemiologist instead of key opinion leaders. And then this less is more guideline should then lead to less is more evidence-based endoscopy. We simply need more controlled trials of less is more strategies. So if the guideline committees do what we asked them to in that weekend in which they wrote a new guideline for the disease and they reduced the disease burden with 25%, then let them design, and with their GI societies, an appropriate less is more studies, and then have these GI societies go up to the healthcare providers and governments to get these funded. Because the adjusted guidelines save them money. And in return for saving that money, it's pretty appropriate that they then should fund appropriate healthcare evaluation. And when I pitched this idea about 4 years ago, nothing happened. But now we're, at least in my country, we are, again, Barrett's Lane. This is called the Barrett's Surveillance Icebreaker Project. We're actually going to do what I just suggested. So we're going, this is the current situation in my country. If you get diagnosed with the Barrett's in your local hospital, if you are a high-risk Barrett, so if you have dysplasia or a cancer, you get referred to a Barrett's Expert Center. If you have a non-dysplastic Barrett's, you stay in your own hospital for being surveyed, arbitrarily distinguishing a shorter than 5 and a larger than 5 centimeter Barrett's. What we're going to do is that in this low-risk case, so less than 5 centimeters, non-dysplastic Barrett's, we're going to stop surveillance. New guideline, addendum to the Dutch guideline, stop surveillance in these patients. That eliminates 70% of all surveillance, Barrett surveillance endoscopies for non-dysplastic Barrett's in our country. And with the money saved, we're going to register these patients. We're going to follow them up for 10 years on the backhand side. We're not going to contact them, but we're going to look at our cancer registries and our mortality registries to find how many of these patients actually develop symptomatic cancer or die from esophageal cancer. And we're going to monitor that every year so that we can stop if we prove to be wrong. All the simulations that we do, we're pretty sure that that is a useless thing to do, to survey these Barrett's patients. So we're pretty sure that we are going to finally find the evidence, but we're not going to research it and then they're going to stop. No, we're going to stop now and use the money to do something better. And for these Barrett's larger than 5 centimeters, there's still no evidence to survey these patients, but it's pretty horrendous to stop surveillance here. So what we're going to do, these can only be surveyed if they are surveyed as part of a healthcare evaluation. So they're going to be referred to the Barrett's Expert Centers, and once they are there, we're planning to do a randomized trial comparing endoscopic surveillance, so the standard, with non-endoscopic surveillance using a cytosponge. Again, reducing instead of expanding. And we think a non-inferiority design will likely show that that sponge, if you do it every 1.5 years, is just as good as scoping them every 3 years. Again, improving care and reducing unnecessary endoscopies. And finally, what can you do? What can every practicing endoscopist do if they want to do less is more? Please stick to the guidelines, because I know many, many colleagues who do a little bit more than the guideline. After a colonoscopy, or again, a Barrett surveillance, they will put their hand on the shoulder of the patient, and they will say, well, the guidelines say that we should see you back after 3 years or 5 years, whatsoever, but I just think it's good that I see you back next year. We all know those doctors, they are there. The patient thinks that that doctor is taking appropriate care of him, whereas we know that that is overutilization and driven by the wrong reasons and maybe also financially. So we should hunt down these overutilizers. So we should stop reimbursing those unnecessary endoscopies, logically. And we have so many quality parameters. Why don't we have a quality parameter that actually nails down these unnecessary endoscopies? And I think we should educate our patients or educate society. Instead of feeding into the carcinophobia, speak about not doing an endoscopy, not being sent to surgery. It should be part of the shared decision-making process. And maybe our informed consent should state that the option of not performing an endoscopic procedure has been considered and discussed. And then finally, we need to prepare our young colleagues. Instead of feeding uncertainty in them, making them afraid of missing out and failing, we should give them the confidence and the knowledge of what overdiagnosis utilization brings as part of the GI training curriculum. So I think it's time for less is more endoscopy, because just because we can doesn't mean we should. Thank you very much.
Thank you, Jacques, for this outstanding presentation. There's a comment from Dr. Rajabali from the internet, and he says, excellent eye-opener. I think we cannot better say thank you for this revolutionary presentation. My question is to you now, if you decrease the surveillance of Barrett's, what will happen, or what will you tell the patient? Because I'm sure one patient will come back out of this group and will have a Barrett's cancer, which was overlooked in the previous endoscopy.
There's two answers to that. If we consider this to be the new standard and it's in the guideline, that any new Barrett's that is being diagnosed will simply be explained that he was screened for something that he doesn't have at that time, and that there's no need to look at him endoscopically. So none of these patients will worry. But if we change something that the patient has gained or owns, then we have to be careful. So de-implementing something you have been doing but is considered to be useless and then still stopping it really requires you to really think about how are we going to explain this to our patients? How are we going to make certain that it doesn't feed into their medical consumption or they are not trying to get their endoscopy elsewhere? So the de-implementation process of this is indeed challenging, and we're working on that. But all the simulations that we've done, we anticipate that in this small risk group, in 10 years' time, less than 1.5% of patients will have a symptomatic cancer, whereas their chances of dying of something else is considerably larger. And if we reduce the quality of life of patients being surveyed, and mind you, surveillance is not perfect because patients drop out from surveillance, and even under surveillance, patients can still proceed to get a symptomatic cancer. But if we worry these patients, and they lose quality of life more than 1%, and studies have shown that it's about 20 or 25%. 1% is enough to eradicate the cost effectiveness of surveillance. And then look at how much money you will save and how you can use that money to do something better in healthcare. So we sat down with the Dutch government and with the insurance companies, and the difficulty is that we're going to stop surveillance in all these hospitals in the Netherlands for this larger, low-risk Barrett's cases. Then every hospital will drop about 150 endoscopies a year. So it becomes impossible for healthcare providers to register that and then to pull money back from these hospitals. So we argued that you don't have to, because we're stopping with something that's useless, and the average waiting time for a consultation in GI in our country or an endoscopy in our country varies between 6 weeks and 4 months. So if we pick just a random patient who is on the waiting list, care for that patient is going, per definition, going to be better than the care that we are not longer providing to this low-risk group. So if you put all of that together, the basic answer to your patient is, we cannot cover everything. We have to make choices in life. We have to make choices in healthcare. And we've chosen, with a lot of people that thought about this, that this is not an appropriate investigation for you. And yes, some people will lose their lives because of that, but we're going to save many, many more for doing something better.
Horst.
Thank you, Jack, very much for this very important presentation. So as you well know, there are a lot of studies done in the US on this issue, determining the quality of life, adjusted life years for many screening procedures, new interventions, and so on. And Shyam maybe better explain it, but it's considered if a strategy costs more than 100,000 per QALY, then it's not justified to introduce a new surveillance strategy or treatment approach. So this is the same thinking, although I don't see any consequence in the United States following that. But would this be an option? These are hard parameters, the QALYs.
Sure, if you have adequate data on both sides of the choices that you have, and generally we don't have that. In fact, in my country, I don't think we should be willing to pay 100,000 euros or dollars for a quality of life saved, because we simply will not be able to put the money on the table. We are now thinking that the person who will reach an age of 150 years, that he is already born. My sons will likely become over 100. There's no way that we can continue with healthcare as we're doing now. And the knowledge agenda of the Dutch Society of Gastroenterology is purely driven now by eliminating useless care. So we sat down with the whole GI society of our country, and we spoke to patients' associations, etc. There's a standard way of doing this. All the professional societies in our country have to do that. And we said, we're going to do only reduction of useless care. And our society accepted that. And this Barrett Icebreaker project is one of the 9 questions that came out of this. And now we're trying to push this to get actually being done. We had no issues finding 9 questions. We all hate these indications. I've never met a gastroenterologist, at least in my country, who said, I really love Barrett surveillance. This is really very useful. Everybody, when we reduced the burden of the disease with 40%, everybody said, at last, finally, we're going to make diseases smaller. So a lot of the knowledge here is here in your belly, in your gut. You know that it doesn't work. And that at some point, we don't need the evidence to stop doing that. So instead of our normal way of doing it is write a study, find a grant, wait a year, your grant gets rejected, you try again. After 2 years, you get the grant. You do the research, it takes you 5 years. And after 5 years, you find out that, indeed, it's useless. This is not the way how we should be changing this. No, we should stop, for what we know is unnecessary, and then we should monitor that that decision is wise. Then we're saving the money, we're going to run research that otherwise will be impossible, and we're going to have a lot of money that we can spend on better stuff. So I just object to having put data on the table which are biased in any way, whereas everybody in that guideline committee knows that we can do it. We sat down with all the Dutch Barrett's expert centers, everybody said, yeah, you're right, we need to stop with that. So I'm pretty sure that there is, and we're going to do the same thing for pancreatic cysts, we're going to do the same thing for analysis of dyspepsia in patients younger than 50 years. So we're actually going to, if this flies, we're not letting go of this. And in our country, we are pretty privileged that we actually can do this because the way healthcare is funded allows doctors not to directly make money on the care that they provide to their patients. So I'm a kind of Don Quixote chasing the windmills, but then I'm living in Spain, and it at least flies in my country.
Thank you, Jacques, for this outstanding presentation, and I thank you for the discussion. We are at the end of a wonderful symposium. Thank you very much, Olympus Company, to make it possible. For the information now, we had 550 people in the internet following our program, and there's another question. All presentations will be later available at our EndoSwiss YouTube channel. Thank you very much, and I hope to see you tomorrow morning, 9 o'clock. Thank you.